There is a fact about birth that should fundamentally reshape how you see everything. Not a theory, not an interpretation, a documented, measurable, statistically undeniable fact. One that was known, published, and discussed in medical journals over a century ago, and then buried so completely that most people alive today have never come across it. In 1920, a study compared birth outcomes across two groups of women. The first group was cared for by trained midwives, many of them immigrants, many working in America's poorest neighborhoods, using methods handed down through generations of practice. The second group was attended by physicians educated, credentialed, working in hospitals with the best technology the era could offer. The results should have settled the argument forever. The midwife-attended births showed lower maternal mortality, lower infant mortality, fewer complications, fewer infections, better outcomes by nearly every measurable standard. The women attended by doctors in hospitals were more likely to die. Their babies were more likely to die. The most technologically advanced, scientifically credentialed birth attendants in the country were producing worse results than immigrant women working in tenement apartments with nothing but their hands, their knowledge, and no backup. This wasn't some fringe study. It was published. It was known. And within a generation, the midwives were gone, not retired, not outcompeted, eliminated, driven out of practice by a deliberate, organized, well-funded campaign led by the same medical establishment whose own data proved they were the inferior option. Birth moved from home to hospital, from the hands of women who had done this for millennia to the hands of men who had been doing it for decades, from a process understood as natural to a process treated as a medical emergency. And maternal mortality in America got worse. I need you to sit with that. Not for a moment, for as long as it actually takes to register. The country systematically eliminated the practitioners who were producing better outcomes and replaced them with practitioners producing worse outcomes. And it did this not despite the evidence, but in full possession of it. The data existed. The comparison had been made. The results were clear, and the decision went the other way. This raises a simple but critical question. If the goal was safer birth, why eliminate the safer option? The deeper I went, the more the answer became impossible to avoid, because the goal was never safer birth. The goal was control. Start with what existed before. Because what existed before wasn't primitive. It wasn't superstition. It wasn't old wives fumbling in the dark. It was one of the oldest, most refined, most continuously practiced bodies of knowledge in human history: midwifery. The art and science of attending birth, practiced in every culture on every continent for as far back as human records go. Millennia of accumulated knowledge about the physiology of labor, about the positions that ease delivery, about the herbs and techniques that manage pain, bleeding, and complications, about the emotional and psychological dimensions of birth that cannot be separated from the physical ones. This knowledge was held by women, passed from woman to woman, mother to daughter, mentor to apprentice. It was experiential knowledge, built through thousands of attended births, refined across generations, adapted to local conditions and local bodies. It existed outside institutions, outside universities, outside the credentialing systems that men had built to govern, who was allowed to know what. And it worked. Not perfectly. Birth has never been without risk. But it worked well enough that the human species survived and multiplied for 100,000 years before a single physician ever attended a single delivery. It worked well enough that the data, when someone finally bothered to collect it in the early 1900s, showed that midwife-attended births were safer than physician-attended births even in the poorest, most disadvantaged communities, even without hospitals, even without technology, even without credentials. The silence was deafening when I started tracing what happened to this knowledge in America between 1910 and 1940, because what happened wasn't a gradual transition. It was a campaign, a deliberate, strategic, well-documented campaign to discredit, criminalize, and eliminate midwifery as a practice in the United States. The campaign was led by the American Medical Association and by obstetricians who, in the early 1900s, were fighting to establish themselves as a legitimate medical specialty. Obstetrics was new. It was struggling for respect within the medical profession. It needed patience. And the single biggest obstacle to building a patient base for hospital-based obstetrics was the fact that most American women were giving birth at home, attended by midwives, and doing just fine. The strategy was not subtle. Medical journals published articles characterizing midwives as dirty, ignorant, dangerous. The language was explicitly racialized and xenophobic. Midwives were described as relics of the old country, as peasant practitioners whose methods were unsuited to modern America. The fact that many of these midwives were black or immigrants from Southern and Eastern Europe made the campaign easier. The medical establishment didn't need to prove that midwives were dangerous. It only needed to associate midwifery with populations that the American mainstream already looked down on. The prejudice did the rest. State by state, laws were passed restricting or eliminating the practice of midwifery. Licensing requirements were introduced not to ensure competence, but to create barriers that traditional midwives couldn't meet. You needed formal education, but no school would admit you. You needed physician supervision, but no physician would supervise a competitor. You needed hospital privileges, but no hospital would grant them. The regulations weren't protecting mothers. They were eliminating a rival profession, and they worked. By the 1940s, the midwife-attended home birth that had been the norm for all of American history was effectively over. Hospital birth attended by physicians became the standard, and the medicalization of birth, the treatment of a natural physiological process as a medical event requiring intervention, monitoring, and institutional management, became so total that within a generation, most Americans couldn't imagine birth happening any other way. The pattern repeats with unsettling precision. Because what was lost in this transition wasn't just a group of practitioners. It was an entire framework for understanding what birth is. The old framework, the midwifery framework, understood birth as a physiological process that the body already knows how to perform. The midwife's role was to support that process, to create conditions that allowed it to unfold, to watch for complications and intervene when necessary, but to trust as a foundational principle that the body was competent, that birth was not a disease, that the default expectation was normalcy, not emergency. The new framework, the obstetric framework, inverted this understanding completely. Birth became a medical event. The default expectation became risk. The body was not trusted. It was monitored. It was managed. It was intervened upon as a matter of routine, not because complications had arisen, but because complications might arise. The hospital room replaced the home. The surgical gown replaced familiar clothing. The lithotomy position, lying flat on the back with legs elevated, replaced the upright squatting and kneeling positions that women had used for millennia. And each of these changes, each presented as modern and scientific and safe, actually made birth harder, longer, and more dangerous. The deeper I went into the medical literature, the more I found that physicians themselves had documented this. The lithotomy position, which became standard in hospital births, works against gravity. It compresses the pelvis. It makes the birth canal narrower. It increases the likelihood of tearing. It was adopted not because it was better for the mother, but because it was more convenient for the doctor. The doctor could see better. The doctor could intervene more easily. The position served the practitioner, not the patient. And no one asked the patient, because the patient was now a patient. A passive recipient of medical expertise, not an active participant in her own birth. As if following instructions they didn't fully understand. And here's where the story becomes not just historical but urgent. Because the consequences of this transition are not in the past. They are measurably, statistically, tragically present. The United States of America, the country that spent the last century building the most technologically advanced, most expensive medical system in human history, has the worst maternal mortality rate in the developed world. Not by a small margin, by a staggering margin. American women die in childbirth at rates that would be considered a public health emergency in any other wealthy nation. And the disparity falls hardest on Black women, who die at 3 to 4 times the rate of white women. A disparity that persists across all income and education levels, a disparity that cannot be explained by poverty alone, a disparity that traces its roots directly to a medical system built on the elimination of the practitioners who were serving Black communities most effectively. The midwives who were driven out of practice in the early 1900s were disproportionately Black. The granny midwives of the American South, women who had attended births in their communities for generations, who carried knowledge that predated the arrival of their ancestors on this continent. These women were specifically targeted by state licensing campaigns. Their elimination didn't just remove practitioners. It severed a chain of knowledge transmission that had sustained Black maternal health through slavery, through Reconstruction, through Jim Crow. And the medical system that replaced them has never, in over a century, managed to produce equivalent outcomes for Black mothers. The official explanation collapses here. Because if the medicalization of birth was about safety, the outcomes should have improved for everyone equally. That was the promise. That was the justification for eliminating the midwives, for moving birth to hospitals, for placing it under medical authorities safer birth, better outcomes, scientific progress. And for a century now, the data has shown that the promise was broken. Not for lack of technology, not for lack of spending, but for lack of something that the old system had, and the new system destroyed: trust in the body, continuity of care, knowledge held in community rather than locked in institutions. The presence, during the most vulnerable moment of a woman's life, of someone who looked like her, spoke her language, understood her world, and believed that her body knew what it was doing. The pattern repeats with unsettling precision across every dimension of this story. A system that worked was replaced by a system that didn't work as well. The replacement was justified by data that actually supported the original. The original practitioners were eliminated not through competition, but through legislation. The knowledge they carried was not preserved in the institutions that replaced them. And the populations most harmed by the transition were the populations with the least power to resist it. I want to pause here and acknowledge something that the standard telling of this history usually omits. Modern obstetrics saves lives. Cesarean sections save lives. Emergency interventions save lives. The capacity to manage genuinely complicated births in a hospital setting is a genuine medical achievement. I am not arguing against medical intervention when medical intervention is needed. I am asking why medical intervention became the default rather than the exception. I am asking why a system that produces worse outcomes at higher cost than the system it replaced has been allowed to persist for over a century without fundamental re-examination. I am asking why the United States, which eliminated its midwifery tradition more thoroughly than almost any other developed nation, has worse maternal outcomes than countries that preserved theirs. I am asking why the data from 1920, the data that showed midwives outperforming doctors, was known, published, and ignored. And I am asking the question underneath all the other questions. What else did the old way of birth carry that was lost when the midwife was eliminated? What knowledge about the female body, about the physiology of labor, about the relationship between emotional safety and physical outcome, about the role of community and familiarity and trust in the birth process? What knowledge was held in those hands that never made it into a textbook, because the people who held it were driven from practice before anyone thought to write it down? The deeper I went, the more I realized that what was erased wasn't just a profession. It was a way of understanding the body, a way that trusted the body's competence, a way that treated birth not as a medical emergency to be managed, but as a physiological event to be supported. A way that placed the birthing woman at the center of her own experience, rather than beneath the authority of someone who had studied her experience in a book. That way existed for millennia. It was tested across every culture and every continent. It produced results that modern medicine, with all its technology, all its funding, and all its institutional authority, has failed to match for the populations most in need of safe birth. And it was erased not because it failed, but because it was inconvenient, because it existed outside institutional control, because the knowledge it carried was held by women, transmitted by women, and practiced by women in communities where no institution could profit from it, handed a hospital gown and told it was the only safe option. What else have we been handed and never thought to question?